Hello guys, today I'll be discussing about with you guys is the MRI and the CT appearance for a JNA patient. So how actually a JNA looks like on a CT and an MRI scan. So as a surgeon, before you operate on the patient, you need to know how the JNA is, what are the extensions, what are the origins, what structures are normally involved, which bone is compressed, so where is exactly the origin of this mass. So for all that you need to have a CT scan. So primarily we do a CT scan only, be it a contrast or a plain one, but sometimes in cases like where the mass is originating in the spinopalatine foramen and having an invasion into the cavernous sinus, also it may invade into the intracranial cavity or it may invade the orbit. So in such cases we need to get an MRI as well for a even better study. So I'll begin with the CT scans first as a primary thing. So as a surgeon, the patient comes into the OPD. You should have certain things clear in your history. Is that when the patient is giving history of recurrent epistaxis, be it left or right, so mostly it is a unilateral epistaxis. So that's the first point. The second point is that whatever side the patient is having bleeding from, usually the patient has a nasal obstruction on that side. Okay, so the third point, always remember that the patient is almost always a male and in the adolescent age group. So the patient is quite young. If the patient is quite adult or in the old age towards 60 years and above, so remember in those cases it may not be a pure angiomatous fibroma or the mass. It may be more towards a fibromatous mass and less of angiomatous. So that will be more of fibroma rather than being an angioma. So this JNA has three specific points. It is mostly unilateral, has a unilateral epistaxis and most commonly seen in a male adolescent age group. Okay, so if these points are present for a patient in a history at the OPD and the CT scan is being done, so with the history and a particular CT scan characteristics, we can definitely give it a diagnosis as a juvenile nasopharyngeal angiofibroma, because if you suspect a patient to be having a JNA, the biopsy is always contraindicated. So I'll be telling you guys about these specific points which you can see for on a CT and an MRI scan. So let's begin with the CT scan first. So whenever you have a CT scan, you should always order a 0.5 mm coronal, axial and sagittal scans. It should be 0.5 mm. Remember that it should never be 3 to 4 mm, because very important neurovascular structures may get missed if you order a 3 to 4 or 5 mm scans. So make sure it's a 0.5 to max 1 mm scan. Okay, so you get three sections. You get coronal, axial and sagittal, because as a surgeon you always operate in a coronal section. Okay, so in front of you guys you can see is a coronal section. So we start from the most anterior aspect over here and to the most posterior aspect over here. So following the scan is the same. So as you can see over here, the first thing you should remember is that you should directly look for the nasal cavity and any haziness in the nasal cavity. So I see the frontal is clear. Okay, the frontal is well lumitized and clear. There is no opacification I can see in the nasal cavity so far. The septum appears to be almost in the midline with a septal bulge in between. So I still do not see any nasal mass or whatsoever deviation of any kind, except for the fact that I start seeing some opacification over here in the maxillary sinus, which could be because of the secondary obstruction or maybe the secondary obstructive sinusitis. So that's the only one finding which I can see over here. As it go on behind, the maxillary sinus appears to be much more opacified as compared. So if I zoom in this, you can see over here, it is much more of a collection as we go towards the posterior aspect. So as we go posteriorly, we can see the same image. We can see collection in the maxillary sinus. We can see the same collection going on, and that is increasing as we go posteriorly. So as you can see over here, this opacification in the maxillary sinus is quite extending well beyond the lateral margin of the maxillary sinus. So as you can see over here, as we go laterally and posteriorly, we can see a common communication between the infratemporal fossa and the maxillary sinus and the nasal cavity. So as you can see over here, this is the nasal cavity, that's the maxillary sinus, and that's the infratemporal fossa way behind. So as we are going from the anterior to the posterior aspect, what we can see is a direct communication between these three regions. And so we can conclude this one thing, that there is bony destruction. So that's first point we can see. So what's the second point you have to see is the origin of the mass or any other compression you can see, or any other bone destruction you can see. So all you can see is collection in the right sphenoid sinus. You can see also, you can see appreciate the onary cells which is present on both sides. You can see this is the left onary, this is a right onary over here. So the right sphenoid is fully opacified, the right entire pterygopalatine fossa is involved. The communication between the pterygopalatine fossa and the infratemporal fossa is also very much widened over here, as you can see. So this is what we could see so far on the CT scan. So if we go behind on the same CT scan, we can see a lot of widening of the spinopalatine foramen. So whenever the mass you suspect it to be as a JNA, the first thing you need to see is for the spinopalatine foramen of the normal side. Okay, so that you can compare that with the affected side. Now to look for the normal side spinopalatine foramen, you have to follow the left maxilla, which is the normal side. So you have to go up to the posterior most aspect of the left maxilla, and as you can see over here, this area is the left side posterior most aspect of the maxilla. And you can see over here, I'll just zoom in this for you guys. As you can see over here, this is the lesser wing of sphenoid. That's the middle cranial fossa, because adjacent to the sphenoid sinus is the cavernous sinus, and that lies in the middle cranial fossa. That's the temporal lobe of the brain over here. And as you can see, that's the onary, that's the sphenoid. That's the nasopharynx. You can see the inferior turbinate posterior most aspect. You can see the maxillary sinus, which is conical in shape. That denotes that it's the most posterior aspect of the maxillary sinus. So the first thing is that there's a widening of the foramen over here. That's the first thing how you can identify that it's a JNA. So moving on to the furthermost posterior aspect, you can see this scan. You just have to follow the homogeneous opacity. You're just going to follow it posteriorly. You want to see whether it is invading the inferior orbital fissure and entering the orbital apex, whether it is going into the cavernous sinus, whether it is invading the skull base and entering into the intracranial cavity. So all these points you need to look out for. Now, as you can see over here, if I zoom in this for you guys, as you can see over here, this is the area which I just showed you some time back as the area of the spinopalatine foramen. This is the same area which is quite widened up, and this is the area of the inferior orbital fissure. We can appreciate some amount of homogeneous opacity which may be entering into the inferior orbital fissure. As you can see, it's the same opacity which you can see still going inside the inferior orbital fissure. That same opacity is not seen over here. As you can see, this picture is quite different with this picture over here. So we may say that the JNA is extending into the orbital apex, or into the orbit at least, through the inferior orbital fissure. So we may have to pull the JNA mass down while operating on this patient. So that is the first thing. Also, we need to know whether it is invading the cavernous sinus. Now guys, this level is at the, if you take a coronal section, which it is, this is at the level of the orbital apex and the inferior orbital fissure. So as we all know, cavernous sinus will not be appearing at this level because it is still on a posterior most aspect. Inferior orbital fissure enters the orbit from an inferior aspect. The orbital apex is a huge structure which consists of the superior orbital fissure as well. So the orbital apex is nothing but the anterior communication or the continuation of the cavernous sinus. So if we keep on going behind, the orbital apex will be continuing as the cavernous sinus. So as we go posteriorly here, as you can see over here, we can see the anterior clinoid process. We can see the optic nerve depression over here. We can start seeing the bulge of the internal carotid artery over here, and we can see the Onuri cell quite clearly on this side. So the patient is having an Onuri cell right here, and the optic nerve will be having a bulge in the Onuri cell right here. And we can see a complete opacification of the right sphenoid with a minimal air gap. And you can see this is the area of the pterygoid wedge, the pterygoid plates. Now, the epicenter, the origin may be the superior lip of the spinopalatal foramen, but the origin of the JNA, the epicenter of the JNA, is the so-called pterygoid wedge or the pterygoid body. That's the center of the pterygoid body called as the pterygoid wedge. So as you can see over here on the normal side, you can see these two foramens over here, right? The median is median and the lateral one is the rotundum. That's the V2 maxillary nerve. So you can hardly appreciate the foramen rotundum right here. So you can see over here, that's the foramen rotundum, and you can hardly see the Vidian canal because the mass, the so-called JNA, has engulfed the Vidian canal. So for a surgeon, if you are watching this CT scan, the surgeon will decide that he also has to enter the Vidian canal, drill the Vidian canal, has to sever the nerve off, cut the Vidian nerve off, and drill the entire Vidian canal, because if you leave the JNA extension in the Vidian canal, the patient will definitely have a recurrence in 3 or 6 months. Give it 1 year, the patient will come back with a huge nasal mass once again, because you left out some mass in the Vidian canal. So that is also very important. So you always have to compare the normal side with the affected side for your reference. So you can see over here, that is the foramen rotundum, which is very much lateralized, and you can compare the rotundum from here. So you can see, we can see the maxillary nerve, but we cannot see the Vidian nerve or the Vidian canal. So that's one thing. The second thing, as you can see over here, this is the medial pterygoid plate, that's the lateral pterygoid plate, that's the pterygoid wedge, or you can see the pterygoid body. Same thing you can see over here, that's the pterygoid wedge, the pterygoid body. Same thing you can see much more clearly is the pterygoid wedge or the pterygoid body, the medial pterygoid, the lateral pterygoid, and the choana over here, and the left sphenoid, the anterior clinoid, and posterior with the posterior clinoid. So if you compare the same thing with the right side, you can definitely see that the pterygoid wedge is completely involved. Now you can look at the opacity over here is very much different as compared to the left side, which is normal. So here it is blackish gray, here it is completely gray opacification. Okay, so this is the complete JNA mass in the pterygoid wedge. So as a surgeon, you also need to drill out the pterygoid wedge. You have to go within the pterygoid wedge, the center of it, and you have to drill out the entire pterygoid wedge till you get that JNA out. Because if you do not, just like the Vidian canal recurrence, this may also recur, and in 6 months duration or 1 year duration, the patient will have a huge mass the way it is now. Okay, so you got to be very careful as a surgeon that you read your CT scan very carefully. The important areas to look for is the Vidian canal, then is the pterygoid wedge, then you have to look for the sphenoid sinus invasion, the nasal cavity, the nasal floor, the choana. See, for a JNA, now the pathway which a JNA follows is almost always similar. It follows certain fixed anatomy. It has a particular area only where it can invade. It has particular areas where it will never invade or never, have an attachment to. So areas like sphenoid sinus, it never attaches itself to. So remember this very carefully. JNA has no attachments in the sphenoid sinus because it does not attach itself. Also, JNA does not attach itself on the nasal floor. So the entire nasal floor should be clear, the sphenoid sinus should be clear. So whenever you're removing a JNA mass, you just have to pull the mass from the sphenoid sinus. There will be no attachments whatsoever. Although JNA has attachments to the nasal septum, the nasal mucosa, the roof of the what do you call the choana. So it enters the sphenoid sinus not through the sphenoid ostia but through destruction of the floor of the sphenoid sinus, or you can see the roof of the choana. So as you can see, the pterygoparietal fossa, which is around here. Now, as we saw that the pterygoid wedge is completely involved, the Vidian canal is involved, the medial pterygoid plate, the floor of the pterygoid body is all destroyed. So we have to drill it out, take the mass out. Now, to make it simple for you guys, even further in detail about the CT scan, you need to know that the pterygoparietal fossa is a crossroad. So it is a small area, but it is a huge crossroad. So the origin is the superior lip of the spinoparietal foramen. So from that area, the JNA may enter medially into the nasal cavity, like here it is doing. It's entering medially in the nasal cavity. That's the first thing. It may go from the nasal cavity posteriorly into the choana. From the choana, it may erode the roof of choana, may enter into the sphenoid. Okay, so that is how it goes. It will never enter through the natural ostia. Remember that, guys. So from the foramen, it enters medially into the nasal cavity. From the nasal cavity, it goes posteriorly into the nasal choana. From the choana, it goes above by destroying the roof of the choana, or you can see the floor of sphenoid. So into the sphenoid. Okay, so that's how it goes. If anteriorly it enters, it extends up to the nasal tip. That's the nares. So that is the anterior extension. So if it has to go laterally, here in this case, it will go through the pterygoparietal fossa, enter into the infertemporal fossa through the pterygomaxillary fissure. So that is how it goes laterally. So if it has to spread even further laterally and anteriorly, it may destroy the zygoma bone, and it may come out of the zygoma bone, and it may have a bulge in the cheek area. So it may have a bulge in the cheek area. So if it goes posteriorly, it may enter, as I showed you some time back here, the Vidian canal. This was the, where it was exactly, yeah, this was the Vidian canal on the normal side. This is the Vidian on the affected side. So it enters the Vidian canal. It enters the Vidian canal and goes posteriorly. Once it goes posteriorly, it enters the foramen lacerum, and from the foramen lacerum, it may have a route of entry into the middle cranial fossa. So that is how it spreads posteriorly. Now, we could see that the area just above the foramen was the inferior orbital fissure. Yeah. So this was the area of the foramen right here, and this was the area of the inferior orbital fissure. So we could see that the mass is going into the inferior orbital fissure, into the orbital apex. So this is also yet another route that it can enter through. So if it is an extensive case, it may enter into the orbit. It may enter through the superior orbital fissure as well. It may go and erode the skull base over here, and it may enter the intracranial cavity as well. Now, if it enters the sphenoid and it's a huge mass in the sphenoid, now from the sphenoid, the JNA will never enter the cavernous sinus. Okay, as I said, the JNA does not have any attachments in the sphenoid sinus. It is free lying there without any attachments. But how does the JNA then enter the cavernous sinus? It's very simple. It enters the cavernous sinus by destroying the pterygoid wedge, the pterygoid plates. And what do we have just behind and above the pterygoid plates is the cavernous sinus. Now I'm going to show you very clearly on the scans over here. As you could see over here, that was the area of the carotid bulge. That's the area of the optic. Now, the moment you start seeing the carotid artery on the lateral aspect of the sphenoid, that's the area of the cavernous sinus on the CT scan. So this area is the cavernous sinus, and what do we have just below that is the pterygoid wedge. So once the pterygoid wedge is destroyed, it destroys everything over here and directly enters the cavernous sinus. So basically it's a trans-pterygoid approach if we have to remove the tumor in the cavernous sinus. So we may use a trans-pterygoid approach, which will be very easy for a surgeon because already the pterygoid is damaged by the mass itself. So this is how basically you should learn to read a CT scan of a JNA patient. So all these points, whatever I spoke about some time back in this video, you have to be very careful of. All these points are very important. So this is how you read a CT scan for a JNA patient. And what you see over here is the foramen ovale. So that's the foramen ovale, which you can see over here. That's the foramen ovale through which the contents MALE pass through. So that's the foramen ovale for you guys on a CT scan. So this is how you read a CT scan for a JNA patient. Now this was a plain non-contrast CT scan, and that too it was a bony window. Now this was a bony window and not a soft tissue window. So if we move on to the MRI of the patient, you can see now this is the axial section of the CT scan. Similarly, we need to know the axial section. Now, if in your Viva exams, in the theory exams, if the examiner asks you a spotter for Holmen Miller sign, so if you're asked what is the Holmen Miller sign, you need to know what is the Holmen Miller sign. Now, for that, we need to understand what exactly is Holmen Miller sign. Now, if you look at this, this is the left maxilla, and that's the right maxilla. You can hardly visualize the right maxilla. The right maxilla is nowhere to be seen, right? It's all opacified, and wherever you can see is the JNA everywhere. The JNA has entered the pterygoparietal fossa, the infratemporal fossa. Now, as you can see over here, now this is the right maxilla and that's the left maxilla. So if you can see, this is the level of which you can see the posterior wall of the right maxilla, and this is the level where you can see the posterior wall of the left maxilla. So as you can see, this is the distance by which the posterior wall of the right maxilla has been shifted anteriorly. So if the JNA is pushing the posterior wall of the maxilla anteriorly, that bulge, that bowing, that anterior bulge is called as the Holmen Miller sign. Okay, so as you can see over here, this is the Holmen Miller sign. This is the entire JNA over here. That's the pterygoid body. That's the pterygoid body being destroyed over here. That's the intranasal part. That's the pterygoparietal fossa. That's the infratemporal fossa. As you can see over here, you can see that's the infratemporal fossa on this side, and on this side it's completely invaded. So this is a huge extensive JNA of this patient. So that is how you can look for the JNA on the axial scan. You can see this is a nasolacrimal duct over here. So as you can see, even the posterior wall of the maxilla on the right side has been breached, and still the JNA is coming into the maxillary sinus through the posterior wall. So you can imagine what extension this patient is having for the JNA. As you can see in this scan, the JNA mass is almost on the anterior lateral wall of the maxilla, almost adjacent to the nasolacrimal duct over here. So this is a huge anterior extension of the JNA. So this is how you can, judge the extent of the JNA on a CT scan. So yeah, that is all about the axial scan. So if you move on towards the axial, okay, that's same axial. Now, okay, so moving on to the MRI scans now. Now the MRI scan is equally important if the patient is having the orbital cavernous sinus and the intracranial involvement. Now what you see in front of you guys is a T2 scan. Now why T2 you say? Because you can see this is the globe and is having an illumination. So this is a T2 scan. If you see closely, now what is JNA? Now JNA is a huge, highly vascular mass. So if it's a T2 scan, or most important, if it's a post-contrast T1 scan, the JNA will definitely flare up. Okay, it will have a huge flare up. As you can see, this is a T2 scan, and you can see if I zoom in this for you guys, yeah, you can start seeing the mass over here. You can start seeing the mass over here. It's completely going laterally. So if you can see over here, that's the orbit. You can see the orbital muscles as grayish. This is the mass where you can see to be appearing as bright white, which is illuminating. So if I go further behind and show you the extension, you can see this is a sphenoid sinus now. The right sphenoid is completely opacified. Now, being a T2 scan, all collections, now remember this point very carefully, all fluid collections on T2 scan appear to be as bright white. On T1 they will appear as gray, but on T2 they will appear as bright white. And you can see, as we saw on the CT scan, it was completely opacified with collections. So in those scans, we could not differentiate whether it was the mass or the collection. So this is where the MRI plays a very important role. Now, as you can clearly see, this is the JNA. We can see here right there. This is the JNA. This entire thing, I'll just zoom in this for you guys. As you can see, this is the collection over here on the sphenoid sinus, and this is the JNA. You can clearly see that there's a huge difference. This is completely bright white, and this is kind of grayish white. So this thing over here is the JNA mass, and this thing over here is the collection. So on the CT scan you cannot differentiate that, but on the MRI you can definitely do that. So this is nothing but a sphenoid sinus, and what you see, this is the temporal lobe. That's the temporal lobe. That is almost the area of the orbital apex. So you can see the JNA entering into the orbital apex inferior aspect. So this is how MRI is really important and useful. The same thing you can see over here. This is the orbital apex, almost at the area of the cavernous sinus, and there is a minimal collection I think you have in the cavernous sinus as well. So for sure it has invasion in the orbital apex. It may minimally have an invasion in the cavernous sinus as well. So all you can see, this is the JNA mass. You can see over here extending into the infratemporal fossa, and that's the normal side. You can appreciate the normal side as grayish because these are all the muscles. You can see the grayish white bright, which is the mass having a contrast enhancement, having a T2 enhancement. And this is, you can see, somewhat grayish. That's the muscles in the infratemporal fossa right there. So this is how the MRI is really helpful in differentiating the exact area of collection and the mass. Okay. So I think the concepts about the mass on the CT scan and the MRI scan is completely clear for you guys. So if you see this T2 scan, you can see this mass having a complete illumination. Now this is a T1 post contrast scan for you guys. Now this is a T1 scan. Okay, now this is a T1 scan because there is no illumination in the globe, so that's a T1 scan. But this is a T1 post contrast scan because, as you can see over here, these are the orbital muscles. Over here you can see this is the medial rectus, that's the superior oblique, that's the superior rectus over here. I'll zoom in this even further for you to have a clear idea. That's the superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique right there. Now, normally on a T1 and a T2 scan, guys, muscles will not illuminate. Only and only on a T1 post contrast scan, because muscles have blood vessels in it, it will have illumination. So you need to know the difference between them. So this is a T1 post contrast scan, as you can see over here, and as you can see, the entire mass is having a huge flare up over here, and you can see this is a huge mass over here. That's the orbit. So the blood vessels and the JNA mass will take up all the contrast and will show the mass as this. So if we keep on going posteriorly further, you can see a huge illumination in the mass right there. So you can see the mass in the infratemporal fossa in this section. You can see it in the sphenoid sinus as well, in the pterygoparietal fossa as well. That's the ICA. You can see the internal carotid artery having two loops. That's the cavernous sinus. As you can see, this white illumination is the cavernous sinus. Now you can actually see the cavernous sinus on a T1 post contrast. This is the pituitary gland you can see over here. That's the pituitary stalk, which you can see over there. That's the cavernous sinus. That's the cavernous sinus. This is the cavernous sinus. I cannot see any cavernous sinus invasion at this point. What you can see here, this is a mass. That's the collection. That's the internal carotid artery in the cavernous sinus. So I cannot see any invasion in the cavernous sinus itself. So I think the patient's cavernous sinus is free, and I think the MRI is not showing any cavernous sinus invasion. The internal carotid artery looks to be normal. The cavernous sinus looks to be free of any any JNA invasion whatsoever. So this is the importance of the MRI scans in studying the JNA case. So I hope I showed you the T1 post contrast, the T2, and the CT scan bony window for the complete evaluation of the JNA. So I hope next time you go and operate on a JNA patient, the CT and the MRI becomes really easy for you guys. So I hope you like and subscribe to my channel. So till then, see you guys next time. Thank you.